So thank you everyone for joining today's first ever Lunch and Learn series where we're going to be covering the No Surprises Act. For those of you who are not familiar with me, my name is Courtney Stevenson and I am the Payor Contracting Specialist for Health Professionals Alliance and Data DX Consulting. I'm really excited to share the information that's coming as it relates to the No Surprises Act. And the purpose of this Lunch and Learn is really for you as the attendee to be equipped with the knowledge around what the No Surprises Act is, why it matters, and how you can prepare your practice. So just a couple of housekeeping items. If you have any questions that come up, I'm not going to be addressing them until the end of the presentation, but go ahead and send them in the chat. This presentation is being recorded and it will be sent out after for you to watch again or share. And then if you could just please mute yourself and then turn your camera off to maximize bandwidth. I'm going to be doing that myself. So we're going to go ahead and get right into the material. Today we're going to cover what is the No Surprises Act. We'll talk about protected services. I'm going to go over the consent and out-of-network rates and cost sharing, the dispute and arbitration process, how to prepare your practice, what the payers are doing, and then we'll wrap it up with just a quick summary of what I've gone over. Hopefully you'll have some tools to take away to best prepare your practice. I will also, towards the end, as I'm wrapping up, will guide you to a screen of different resources where you can access good information and tools to help you get your practice prepared. All right, so jumping in a 2020 poll conducted by Kaiser Family Foundation, 1/3 of insured adults ages 18 to 64 reported that they received an unexpected medical bill in the past 2 years after they or a family member received care from a doctor, hospital, or lab that they thought was covered, but that their health plan didn't cover the bill at all or covered less than expected. In the same Kaiser Family Foundation poll, almost 67% of adults surveyed said they worried about unexpected medical bills more than they worried about affording other healthcare or household expenses. Healthcare costs continue to increase, and as more employers are offering high deductible health plans to their employees, patients are already shouldering a greater financial responsibility, and it is estimated there are more than $64 million per year in additional out-of-pocket payments made to physicians for emergency care provided out of network, compared with what patients would have paid for the same care in network. Surprise bills are on the top of the list of affordability concerns for many. And not all health plans are built the same, and not all patient benefits are identical. So some health plans pay for out-of-network services while others don't, except in an emergency. This implies that there is considerable scope for consumer protection legislation to reduce patients' financial burden associated with surprise out-of-network bills. To get a handle on the ever-increasing healthcare costs, Congress passed the No Surprises Act in December of 2020. The purpose of the No Surprises Act is meant to mitigate patients' exposure to surprise medical bills and require payers and providers to resolve payment disputes for out-of-network care independently or to use a new defined arbitration process. While public health insurance programs like Medicare and Medicaid already prohibit balance billing, consumers with job-based coverage or individual health plans frequently and unknowingly accept care from an out-of-network provider before they receive a surprise medical bill. Effective January 1st, 2022, the No Surprises Act aims to put a stop to that. Most group health plans that offer group or individual health insurance coverage have a network of providers and healthcare facilities that agree to accept a specific payment amount for their services. Providers and facilities that are not part of a plan's network usually charge higher amounts than the contracted rates the plans pay to in-network providers. When an individual with health insurance coverage receives care from an out-of-network provider, their health plan usually does not cover the entire out-of-network cost, leaving the individual with higher costs than if they had been seen by an in-network provider. In many cases, the out-of-network provider may bill the individual for the difference between the billed charge and the amount paid by their plan or insurance, unless prohibited by state law. This is known as balance billing. Surprise billing occurs when a patient unknowingly receives care from an out-of-network provider and is responsible for all or a large portion of the cost. This can occur when patients are unable to choose an in-network facility or provider because they are receiving emergency care or scheduled care, and their care team includes an out-of-network ancillary provider. It is important to understand who may be impacted by the new regulation in order to ensure proper preparation and implementation. The No Surprises Act applies to comprehensive individual and group health plans, including fully insured plans sold through the individual and group markets, as well as self-funded plans, often referred to as ERISA plans. It does not apply to HRA or other account-based plans, voluntary dental and vision plans administered under a separate policy or agreement, or retiree-only plans. The No Surprises Act does not apply to standalone dental plans for its balance billing prohibitions, directory provisions, advanced explanation of benefits, and other transparency requirements. The law extends across all providers, including a physician or other healthcare provider who is acting within the scope of practice of that provider's license or certification under applicable state law. It also extends to emergency facilities that include a hospital emergency department or an independent freestanding emergency department. Protections also apply to air ambulance services and include medical transport conducted by helicopter or airplane for patients. States have historically been leaders in enacting surprise billing protections. There are currently 34 states with surprise billing laws in place, but protections vary by state and exclude more than 100 million Americans nationwide who receive their health insurance through federally regulated self-funded plans. Federal legislation is expected to extend surprise medical bill protections to more than 135 million people estimated to be covered by employer self-funded plans, as well as millions more in states without protections. Even in states with enacted protections, they typically only apply to individuals enrolled in health insurance coverage, as federal law generally preempts state law that regulates self-insured group health plans sponsored by private employers. Additionally, states have limited power to address surprise bills that involve an out-of-network provider. However, federal law gives little deference to states, and in many cases, it may supersede or possibly enhance existing state laws, such as by adding new circumstances under which patients would be protected from balance bills. The law does not prohibit states from enacting and enforcing more restrictive protections. The law does give explicit deference to state law where states have an established process for cost or rate calculation related to arbitration or payment amounts. Physicians in states with surprise billing legislation will unfortunately have to navigate parallel federal-state systems, which may prove to be very challenging for small practices. To ease the regulatory burden, some states may consider aligning their laws with federal regulation. As mentioned on the previous slide, the No Surprises Act was designed to protect commercially insured patients from surprise bills, including those enrolled in individual, group fully funded, and group self-funded plans. The types of providers that will be impacted are far more reaching than one might expect, Act, and you'll hear me mention these providers multiple times throughout this presentation. The provider types include emergency room physicians, providers that a patient typically doesn't select, such as a hospitalist, a radiologist, anesthesiologist, pathologist, or neonatologist, air ambulance companies, most out-of-network providers, and any non-emergency care delivered by an out-of-network provider at an in-network facility without obtaining patient consent 72 hours in advance. A study has estimated that 79% of ground ambulance providers used for emergencies were out-of-network. Under the No Surprises Act, there is notable exception for ground ambulance transportation, and unfortunately, patients who are transported to a facility by an out-of-network ground ambulance can still receive a balance bill. There are certain services that can be balance billed as long as the appropriate notice and consent process is followed, which I will cover on the next slide. The No Surprises Act does allow for select exceptions to surprise medical bill protections, but only if a patient knowingly and voluntarily agrees to use an out-of-network provider for non-emergency services. A very complex process, there are very specific standards around the notice and consent requirements for out-of-network providers, providing items or services at in-network facilities. When non-emergency services are provided by a non-participating provider at a participating facility or at a non-participating emergency facility, providers may not bill beyond the allowed cost-sharing amounts unless the patient is provided with written notice and consent waivers within 72 hours of the appointment. The notice must be tailored to the individual patient in each circumstance, including identification of the provider or facility and a good faith estimate of the amount to be billed. I'll cover more about good faith estimates on a later slide. There are caveats to the consent waiver process. It doesn't apply if either there isn't an in-network provider available in the facility, the care is for unexpected or urgent services, the provider is an ancillary provider that a patient typically doesn't select, such as a hospitalist or a radiologist. The list of providers is also subject to change in future rulemaking. Providers and facilities are required to use the standard notice and consent forms that will be issued by the Department of Health and Human Services for this exception to apply. These forms must be tailored to include certain specific information, including the out-of-network providers and/or the facilities to which it applies, and a good faith cost estimate for the applicable items or services. The notice and subsequent consent will only be valid for those providers or facilities named in the notice. The notice and consent documents must be given to the individual together, and they must be physically separate from and not attached or incorporated into any other documents. The documents may be given electronically if the individual so chooses. As with the disclosure requirements, the notice and consent forms must meet language access and timing requirements specified by the rule. The individual may revoke their consent at any time prior to the furnishing of the relevant items or services by notifying the provider or facility in writing. Providers and facilities may refuse to treat individuals who do not consent, subject to other state and federal laws. The law and regulations require two signatures, one when notice was provided and another for when consent is obtained. But at this time, there's only one signature line on the form. Specifically, the standard document does not include a separate line for the patient's signature with the date to indicate that the patient received the notice. The American Hospital Association has recommended that CMS modify the standard document to include a distinct signature line for when the notice was given, with a separate signature line confirming that consent has been provided. This would remove any confusion about compliance with the notice requirements. And as you can see on this screen, I've captured screenshots of what the consent form and notice looks like, as well as what an estimate would look like. And these forms can all be found on the CMS website. In limited circumstances under the Act, notice and consent requirements do not apply for certain types of non-emergency items or services. And in these situations, the prohibition on balance billing and in-network cost sharing requirements will continue to apply. Again, and as mentioned previously, notice and consent requirements do not apply to ancillary services, including items and services related to emergency medicine, anesthesiology, pathology, radiology, and neonatology, items and services provided by assistant surgeons, hospitalists, and intensivists, diagnostic services, including radiology and laboratory services, and items and services provided by an out-of-network provider where there is no in-network provider who can furnish such items or service at the applicable facility. Further, notice and consent requirements do not apply for items or services provided as a result of unforeseen urgent medical needs arising when a patient receives post-stabilization care and the out-of-network provider or facility has already satisfied the notice and consent criteria. Part of the new process includes determining out-of-network rates and the total amount to be paid to the provider or facility, including any cost sharing, and it is based on a hierarchical order. Out-of-network rates will first be an amount determined by an applicable all-payer model agreement under the Social Security Act. If there is no such applicable all-payer model, the amount may be determined by a specified state law. If there is still no applicable all-payer model or specified state law, an out-of-network rate is agreed upon by the plan and the provider or the facility. This may be based on the lesser amount of either billed charges or the qualifying payment amount, which is generally the plan's median contracted rate. Lastly, if none of the conditions above apply, an amount will be determined by an independent dispute resolution entity. There may be future federal guidance on reimbursements, which may account for the geography, including whether services were conducted in rural or underserved communities, qualifying payment amounts or payers' median in-network rates, non-fee-for-service charges, quality metrics, and facility type. If the determination of cost-sharing amounts are not resolved, the provider will then need to decide if they want to trigger an independent dispute resolution process. Each step of this process may require development of new workflows, which provider organizations need to begin planning for. Key questions of how they will resolve disputes, what payment rates they will accept, and how they will negotiate need to be understood for successful implementation. I'm going to review the process at a high level, but the slide graphic on your screen includes more detailed information and the respective timelines. The first step of the process is required by the No Surprises Act is the requirement that health plans make an initial payment to the provider or transmit a notice of denial within 30 days of the date of bill submission, but it doesn't prescribe the reimbursement amount. Should the provider disagree with the payment or the notice of denial by the health plan, a 30-day negotiation period may begin. If the open negotiation fails to produce an agreed upon rate, then payers and providers will jointly select a certified independent dispute resolution entity. Parties can then submit their proposed rates for the out-of-network services, and the independent dispute resolution entity will issue a binding determination based on the proposed rates and supporting documentation. Both sides make a final payment offer, and the arbitrator must choose one of the submitted offers that is determined to be more reasonable. In determining reasonableness, the Act instructs arbitrators to consider several variables. The qualifying payment amount in 2022 is the insurer's median in-network contracted rate for similar services in that geographic region as of 2019, inflated by the Consumer Price Index for all urban consumers. In 2023, the Consumer Price Index for all urban consumers is added to the 2022 qualifying amount. Demonstrations of good faith efforts or lack thereof to reach a network agreement and any contracted rates between the two parties during the previous 4 years, market shares of both parties, patient acuity, and the level of training, expertise, and quality of the clinician or the teaching status, case mix, and scope of services offered by the facility. The party whose offer wasn't selected by the arbitrator pays the cost of the independent dispute resolution. An important point to call out is the provider's usual and customary or billed charges or the rates paid by federal healthcare programs such as Medicare or Medicaid are not considered here. Both parties will also have to pay an administrative fee, and for 2022, that amount is set at $50 each. There are different conversations the leaders in your practice should be having. Most important is to evaluate the current exposure. Understanding how much of your patient population is out of network and what the impact will be on your practice is vital to minimize negative financial impact. The process should include auditing billing data to identify the extent of surprise billing at your organization. Examine the local regulatory environment. Review any existing surprise billing laws in your state, as the federal law defers to state precedent in certain scenarios. Ensure your practice is providing regular and timely updates to payers to support the provider directory requirements under the Act. This includes any material changes to the provider directory information, adding a new provider to the practice, or notifying if one leaves, any changes to days or hours open, phone number, address, as well as any time a request is made by the health plan. It is also crucial to determine a patient communication strategy. Patient satisfaction is extremely important, and many healthcare consumers will have no idea what the No Surprises Act is and how they may or may not be impacted. So prepare to inform patients of their consumer rights and improve price transparency. Miscommunication can negatively impact both the patient and your practice. Lastly, it is important to prepare your practice for potential negotiation and arbitration. As you're having these conversations, it may reveal that your organization is largely unaffected, or it may reveal that you should begin to prepare for possible impact and potential issues. For practices that are impacted, preparation is essential. Starting at the front lines with a front desk and registration team, there are several things to consider. Increasing training and continuing education of front-end staff is crucial to ensure accurate insurance plan identification, eligibility verification, use of any available price transparency tools, and developing respectful patient interactions that are clear, easy to understand, consistent, and complete. You will also want to review your revenue cycle process. Creating clean claims, reducing the incidence of denied claims, and minimizing bad debt starts with strong revenue cycle management. 40% of denials originate from registration errors at pre-service, one of 3 critical segments of the revenue cycle. The importance of the pre-service processes can't be overstated and are often the responsibility of front desk or scheduling staff. In addition to capturing the accurate and complete demographic and insurance data, as well as completing insurance verification, this process also includes understanding health plan requirements, completing medical necessity screening, obtaining all required authorizations, and communicating accurate cost estimates for patients. Reaching out to payers first instead of patients will be a new practice for many providers. Revenue cycle teams need to reimagine traditional processes in order to comply with the No Surprises Act and be able to not only verify if you are in or out of network for the patient's plan, but also be able to provide a good faith estimate of the cost of services. It will be critical to develop a notification process for patients, as well as a process for obtaining patient consent for out-of-network services. This puts the onus on the front desk to do benefit checks ahead of time. And while time-consuming, it can have a huge impact on your organization. And as such, providers and payers should be reviewing their systems. Beginning on January 1st, 2022, the No Surprises Act entitles consumers to a good faith estimate of expected charges. The good faith estimate requirement is triggered when a patient schedules healthcare services or requests the information, even without scheduling care. The good faith estimate is supposed to enable consumers to compare cost and decide whether to self-pay or use insurance. Upon scheduling or request, providers and facilities must ask if an individual is privately insured, and if so, whether they intend to use their insurance for the scheduled care. If the individual has health insurance, the provider or facility must notify their plan of an estimate of expected charges. This information will then be used by the payer to prepare an advanced explanation of benefits that will then be sent to the patient. If the individual is uninsured or self-pay, meaning they will not use their insurance, they will receive the good faith estimate directly from the provider or facility. The good faith estimate must include expected charges for the items or services that are reasonably expected to be provided together with the primary item or service, including items or services that may be provided by other providers and facilities. The good faith estimate must reflect the cash price for services less any discounts and reflect the total cost of expected care during a period of care. A period of care is defined as the day or multiple days in which the primary service is performed and other additional services that may be furnished in conjunction. So for example, for a surgery, the good faith estimate might include the cost of the surgery, any labs or tests, and the anesthesia that might be used during the operation. If an item or service is scheduled that isn't scheduled separately from the surgery itself, it will generally be included in the good faith estimate. Other items or services related to the surgery that might be scheduled separately, like pre-surgery appointments or physical therapy in the weeks after the surgery, will not be included in the good faith estimate. The provider that initially schedules and furnishes the primary service is known as the convening provider. It is recognized that patients frequently receive care from multiple providers during one period of care, and these auxiliary providers are known as co-providers. For services that involve multiple providers and facilities, the convening providers are required to coordinate with co-providers and include the estimated costs on the good faith estimate for the uninsured patients. However, in 2022, there is flexibility for convening providers, and they will not be required to obtain a good faith estimate from co-providers at this time. Instead, they are, for the time being, encouraged to provide a range of potential costs of services furnished by co-providers if they're unable to receive specific cost estimates. The No Surprises Act also establishes protections for uninsured or self-pay patients from unforeseeable medical costs. The law permits that patients may initiate a patient-provider dispute resolution process when the total billed charges for a provider or facility exceeds the estimate on the good faith estimate provided to the patient by a substantial amount. This amount is defined as $400 more than the provided good faith estimate. This threshold is based on the difference in total charges by a provider or facility, regardless if the services were included in the good faith estimate or not. As we covered earlier, under the No Surprises Act, the prohibition on balance billing does not apply if notice is given to an individual and the individual consents to waiving balance billing protections with respect to the providers or facilities named in the notice. Consent and authorization must be completed 72 hours prior, or in the case of a same-day appointment, it must be given 3 hours prior. Clear communication with patients is key to meet the law's stipulation that patients consent to paying for certain out-of-network services, which more than likely will exceed the in-network cost sharing due per their insurance plan. Looking back at what preparation a practice may need to prepare for the No Surprises Act, it is important to start thinking about how current workflows may need to be updated or reworked to ensure nothing falls through the crack. The No Surprises Act may offer practices and providers additional opportunities to contract with more payers and plans, or to consider reviewing and possibly renegotiating current agreements. Now is the time to review not just out-of-network provider status, but also in-network contracts. Take note of when contracts were last renegotiated and consider starting the conversation with the payers who cover many of your patients. In addition to reaching in-network participation agreements with payers to reduce the financial risk from arbitration negotiations, there will be mounting pressures on lowering in-network rates. Arbitration for surprise bills will create new administrative costs that come from fees expended in each arbitration case and the staff time and resources devoted to managing the process. Lower reimbursement will influence long-term sustainability. In preparation for arbitration, payers are preparing to be able to show the data that they've already been paying lower rates and the reimbursement is justifiable. Now is the time, if you haven't started already, to develop your payer relationships, as well as develop a strategy to optimize your reimbursement. With balance billing being a matter of history by 2022, providers who used to practice balance billing are expected to experience a loss in revenue and a decrease in cash, creating lower operating margins. Eliminating unnecessary waste, improving throughput, and reducing total costs is a key strategy to mitigate the loss in revenues. The team here at HPA and DataDX help our members and clients to review their contracts and understand where there is opportunity. Contract review and negotiations can be a time-consuming process, and our team is here to ease the burden so other areas of your practice can be focused on. Members and patients call or search a health plan's website every day looking for a new provider. Having correct information to guide them to a provider that's in network and accepting new patients requires an up-to-date provider directory. Starting January 1st, 2022, each health plan must have an established verification process, a response protocol, and a provider database, and include in any directory specified information. Verification must occur no less frequently than once every 90 days. Health plans must verify and update the provider directory information and establish a procedure for the removal from the database. Procedures should be in place to remove providers who are unable to attest to network status. Databases should be updated within 2 business days of the health plan receiving information that a provider or facility has changed its network status. Health plans must respond to a member request, whether it be call, email, or web, for information on a provider's network status within 1 business day. Erroneous provider directories will result in inaccurate estimates of in-network rates, which translate to a plan's inability to impose a cost-sharing amount greater than in-network rates. One of the services our team at HPA and DataDX Consulting provides is credentialing and provider enrollment. As part of the process, our team works with the payers to ensure as our client, your practice information and demographics are accurate and up to date. When a provider submits a good faith estimate, it will trigger health plans to create an advanced explanation of benefits, giving patients information regarding not just the total cost of the out-of-network care, but the patient's likely out-of-pocket expenses. There are several requirements related to advanced EOBs, including but not limited to whether the provider or facility is participating, and if they're participating, the contracted rate. If the provider or facility is out of network, the description must reference how the patient can find information on participating physicians at their facility, the good faith estimate from the provider based on the codes expected to be billed, a disclaimer that coverage is subject to medical management requirements if applicable, as well as a disclaimer that the information is only an estimate and may be subject to change. And lastly, any other information or disclaimer the plan deems appropriate. The timing for delivering an advanced EOB depends on when the patient schedules the service or requests an estimate. If the patient schedules the service 3 to 9 days before the intended service date, the plan must submit it within 1 business day after receiving notification from the provider or facility. A scheduling time of 10 days or more from the date of the service will require the plan to provide the EOB within 3 business days of notification. The patient can receive an advanced EOB electronically or via postal mail. The provisions of the No Surprises Act do not require providers or facilities to ask which delivery method patients prefer. However, at the current time, the Departments of Health and Human Services, Labor, and Treasury will not be enforcing the advanced EOB requirement on January 1st, 2022. The implementation is delayed until the departments and stakeholders can appropriately develop and implement the technical infrastructure necessary to carry out the requirements. Payers must anticipate out-of-network situations, identify the potential financial impact, and create a consumer education strategy to build clarity around prices and strengthen knowledge about plan benefits. Leakage reports are one way that health plans track which of their members are utilizing an out-of-network provider. Care coordinators or navigators may be more heavily utilized to help redirect care and educate patients about how to optimize their benefits and utilize in-network providers, which may result in more transitions of care. The No Surprises Act also provides certain patient protections when there are changes in network status of a patient's healthcare provider. If a contractual relationship between a payer or a provider and facility is terminated, the health plan must notify each enrollee that is considered a continuing care patient that a provider that they've been receiving care from has been removed from their plan's network and that the patient has a right to transitional care. The patient may have up to 90 days of transitional care, and during that time, the plan will continue to provide covered benefits and the applicable in-network cost sharing. So while these policies make sense on the surface, there may be many situations that will not fall neatly into place due to the complexity of healthcare coverage and payment, especially when there are items and services where consent cannot be waived by patients, multiple or non-participating providers involved, and any other related issues. The No Surprises Act will resolve 2 underlying drivers of surprise bills. It will require payers to reclassify specific out-of-network care as in-network when determining a patient's financial obligation, resolving instances in which payers set higher cost-sharing requirements for out-of-network versus in-network care. The law prohibits providers from billing patients for more than in-network cost-sharing for most out-of-network care, resolving instances in which providers directly bill patients when payers do not cover their full price, aka balance billing. The No Surprises Act creates new strategic implications for providers and payers. Bargaining powers may shift in contract negotiations. The law may create downward pricing pressure, and providers and payers may benefit from improved financial experience. It also creates new practical implications for providers and payers. They will need to adjust billing and communication strategies, prepare for the new arbitration process, conduct a cost-benefit analysis of when to pursue arbitration. And final key considerations as it relates to your practice is to determine whether the federal ban on surprise medical billing applies to your group practice or physicians within your group. If the ban on surprise medical billing applies, determine whether clinicians are able to participate in the notice and consent process to balance bill patients. Evaluate current requirements for patient transparency and good faith estimates, as well as determine what current workflows and data platforms must be adjusted to meet the new requirements. Lastly, consult internally to determine whether your state has an applicable state law in place. As a result, the No Surprises Act will achieve the primary goal of surprise billing legislation, and patients will be held harmless once the new law goes into effect on January 1st, 2022. Thank you for attending this presentation. I hope you gleaned a lot of information and insight about the upcoming legislation. The presentation, both slides and a copy of the recording, will be emailed out. And please contact me with any questions. My contact information is on the screen. And lastly, as I mentioned at the start of the presentation, there are a number of provider resources to access that you can find good information, handouts, forms, and whatnot for surprise billing. So if there's any questions, we do have some extra time. Feel free to either type them in the chat or unmute yourself. Otherwise, I really appreciate everyone's attendance and hope you are ready for the No Surprises Act.